Shoulder impingement is the commonest reason why people come to see me. It's a condition that describes pain, but usually the pain is not felt in the shoulder itself, but rather over the top of the upper arm. And the reason for that is it's a typical referred pattern of pain. Now, most people with shoulder impingement will be in their middle years, anything between 30 to 60 or perhaps even older in some cases, and frequently will start after a period of unaccustomed activity. So a typical example would be someone who's decided to trim their hedges, and they spend a day using a heavy hedge trimmer at shoulder height, and then later that evening they develop pain over the aspects of the upper arm that's unrelenting and persisting and doesn't settle despite taking rest and anti-inflammatory tablets that they've bought from the pharmacist. And that would be a good reason to go and see your physiotherapist if that's you. Other common reasons are perhaps polishing your beautiful new car. That would be a good way of doing it and quite a common reason. Other examples are people who come to me having played a lot of tennis. Perhaps they're already keen and regular tennis players, but for some reason now they're getting this same pain. They've often tried resting, they've talked to their tennis coach, they've tried some anti-inflammatories, but if the problem's just not settling, then the right thing to do is go and talk to your GP. And very frequently your GP will listen to your story and examine you, and then perhaps prescribe a course of physiotherapy. And that would be a good starting point. But let's say you've tried all that and you return to from your physiotherapist back to your GP with persistent pain. And the GP then might choose to refer you to see a specialist, a shoulder specialist, someone like me, who would then make an assessment of your shoulder. A typical examination for someone with shoulder impingement would look like this. We would just need you to be wearing a strappy top, for example. This would be perfect. And then we'd start by looking at the shoulder, and I have a careful look around the outside, the front, and the side, and the back of the shoulder. And then I would start pressing, and I'd ask you if it hurts. So call out if I hurt you. Any pain there? Good. Any pain around here? No. Good. So there didn't seem to be anywhere particularly tender. Was that fair? Good. Now I'd like to ask you to move your arm, and I'm going to be watching your face to see if it hurts as you move. First of all, can you lift both of your arms forwards and upwards as high as they'll possibly go? And down you come. Does it hurt as you do that? No. Good. Thank you. And now out to the side like a pair of wings. Again, as high as you go. And tell me if it hurts. Ooh, it looked like it hurt then. As you come down, does it hurt? Yes, I can see it's clearly painful through that middle arc of movement. And now we're going to examine how much twist you've got. So bend your elbows, keeping your elbows tucked to your side. Let your arms turn out. And they look the same, and a good amount of movement. And then reach up your back, like going up towards your bra. And I can see she's got good movement all the way up her back. And that seems quite comfortable. Good. And now we do some special tests. I'm going to bring your arm up into this position with the thumb pointing down towards the floor. I'm going to ask you to hold your arm up in the air, and I'm going to push down. Tell me if it hurts as I push down. Does that hurt? Yes, and I can see quite clearly that hurts. And now I'm going to do another test. Does it hurt as I twist you back this way? No. As I twist you forwards, does it hurt? Yes, that hurt too. So both of those are tests, the painful tests were typical of impingement pain. I'm now going to check the strength of your shoulder. Push your hand out against me here. That's very nice and strong. Push your arm up against me here. That's clearly very strong. And pop your hand on your tummy and press in hard onto your tummy. Lovely, thank you very much. So following having listened to your story and then examining you, if I still believe that you got shoulder impingement, I would normally have sent you off for an X-ray. But very frequently the X-ray will not show us anything terribly helpful. Oddly, it tells us lots about the bones, but most problems of impingement relate not to the bones, but to the tendons and soft tissues of the shoulder. And in those circumstances, the best way to look at these tissues is to perform an ultrasound scan. And I have my own ultrasound machine in the clinic, and I will be able to perform an ultrasound scan at the time of your clinic appointment. So you will not need to come back and book another appointment or even go and see a different sort of specialist. And now one of the lovely things about doing ultrasound is that we can screen the tendons dynamically, that is while they're moving. I'm just going to move your arm out. It's not too sore doing that, no. And we're going to watch the tendons move on the screen. And we get a lovely view of your tendons. You're nice and slim, so they show beautifully. And we can see the tendons are in good condition there. And on this example, there is no tear, but very clearly I'll be able to see if there was a tear of the tendon in the shoulder. And having established whether there's a tear or not, we might well then discuss whether or not to have an injection. And if, for example, you do choose to have an injection, I will be able to do it using this ultrasound machine, and I'll be able to watch the needle going in, and I can guide the course of the needle so that I ensure that the injection is delivered into exactly the right spot for you in order that you have the best possible outcome of the injection. Having listened carefully to your story, examined you, got an X-ray and even an ultrasound, we would then discuss how you might like to manage this condition. And generally speaking, there are 3 ways we can treat you. You might decide to have nothing further done. It may be that you just simply wanted to know and understand what your problem is, but you're quite prepared and will accept the ongoing symptoms. And in most cases, I think it's fair to say your symptoms will gradually improve, but may take many months or even a year or so to do so. A second option would be to have a cortisone injection. That's a very strong anti-inflammatory drug that we mix with local anaesthetic, and I would use my ultrasound machine to administer your injection so that it sits in exactly the right spot. And very frequently after the injection, I would recommend you return to physiotherapy after a week or so, and that combination of an injection with physiotherapy will often cure your symptoms. But there's no doubt there are several people, there's a small tranche of people for whom the combination of an injection and physiotherapy, time, rest, anti-inflammatories just fails to settle the symptoms long term. And we don't like repeated cortisone injections. We don't like to do more than 2 a year, as we know now that repeated cortisone injections themselves can do damage to the rotator cuff tendons. And in those circumstances, we would usually recommend an arthroscopic subacromial decompression. And that's, from my perspective, a very straightforward, technically straightforward operation, done as a day patient, so you're in and out on the same day, done under general anaesthetic, so you are asleep. But it's keyhole surgery, and you will recover from it quite quickly, having had a couple of weeks where you wished you hadn't had the operation and will resent me for having suggested it as an option. But over the months that follow, it'll get better and better, and by 3 months, most people will say, "It's fantastic, I'm so much better, thank you." But there's the odd little niggle, and for everyone the little niggle is something slightly different. And then by 6 months, hopefully, you'll have forgotten it ever has happened. You won't see the scars, and you won't even remember which shoulder we ever operated on.